Everyone, and welcome to the Intersection Between Hunger and Health webinar. My name is Serena Gaston, and I am with the Pennsylvania Association of Community Health Centers. We are pleased to have you all joining us today. We have a lot of information to share, so now I will take this opportunity to introduce today's presenters. We have Georgia Barton, Health Innovations Coordinator from the Central Pennsylvania Food Bank. Janice Kopelman, Retired Deputy Secretary, Pennsylvania Department of Health. Judy Dillon, Director of Community Outreach at Penn State Health. Jane Clement Smith, Executive Director from Feeding Pennsylvania. And Kim Prendergast, from a Community Health and Nutrition Consultant from Feeding America. So without further ado, I will now turn the presentation over to Janice Kopelman, who will go over the learning objectives for the day. Janice.
Good morning and welcome. We've come together today to address a timely and important topic. Our objectives for this webinar on the intersection between hunger and healthcare are: 1, to define food insecurity and learn about its prevalence in our society. 2, to understand why food insecurity impacts healthcare. And 3, to learn about ways to collaborate with food distribution programs. As we get started, I have a question for you. True or false? Hunger and food insecurity mean the same thing. Please take a moment to enter your response.
Look at it go. Look at everyone jumping in. Thank you so much. We'll give everyone about 15 more seconds to enter your response, true or false. And 5, 4, nobody wants to count down. All right, with the resounding 80% of our participants answer as false. Hunger and food insecurity do not mean the same thing. Perfect. Thank you, everyone, for your participation.
Thank you. Hunger is a feeling of discomfort that's caused by a lack of food coupled with a desire to eat. We've all experienced hunger at one time or another, and we know what it feels like. It's personal and a physical sensation. Hunger is a universal experience, but not everyone is food insecure. Food insecurity is the state of being without reliable access to a sufficient quantity of affordable and nutritious food. Food insecure people have periods where they don't know where their next meal is coming from. Either they cannot afford to buy food or they don't have access to food. Among the food insecure are children in urban settings, families in Appalachia, elderly people who are forced to decide between buying food or medicine. They could be your neighbors, friends, or students. Right now, we'd like to share a short and powerful video with you that features a healthcare provider whose comments are both insightful and personal.
And just so those folks, our participants, are aware, the video will play on the screen. If you have speakers at your computer, you'll be hearing the audio through that. The audio will not come through your phone. So just hang in. It's a very short video. If it doesn't play for you, we're going to be sending you the link anyway. But it is a very impactful video.
What is food insecurity? Food insecurity is the lack of access to enough food for a healthy, active life. Imagine if you had just enough money to buy food with nothing left over to pay for utilities, transportation costs, or all the other incidentals that come up in life. What would you do? Those struggling with food, hunger, and insecurity face these tough decisions every day, and those decisions can have serious and lasting consequences. Hunger with food insecurity should be a concern for all of us because it affects people from all walks of life. Many Americans are one paycheck, one emergency, one job loss, or one medical crisis away from food insecurity. But some people, children and seniors in particular, may be at greater risk of hunger than others. I'm going to turn it over now to Kim for a closer look at food insecurity and poverty.
Thank you so much, Janice. My name is Kim Prendergast, and I work with Feeding America. And I wanted to talk a little bit about understanding who is food insecure and how we can identify those individuals. It's important to understand that food insecurity can occur in many households, so we can't make assumptions about food access based on income. In 2016, 12.3% of households in the United States were food insecure. That was 42 million people and 6.5 million children. And as we think about the intersection of food insecurity and poverty, we know that they're related, but they are not the same. Poverty is just one of many factors associated with food insecurity. In fact, unemployment and low household assets and certain demographic characteristics can be a greater predictor of households that will lack access to adequate and nutritious food. In 2016, in that same time frame, about 40.6 million people were in poverty, including 13.3 million, or 18% of children. And 42 million Americans live in food insecure households. So we know that there's a big overlap, but about 2/3 of individuals who are living below the poverty line are in fact food secure, because they have other benefits they can rely on. They access SNAP benefits. They might access WIC benefits and school lunch and school breakfast for the children. So we find that there are many individuals who might have higher incomes living above the poverty line who are food insecure. And we know that there are some household characteristics that make individuals more likely to be food insecure. And on the next slide, we'll show the national average being 12.3%, but there are certain households that tend to be much higher, at much more risk of food insecurity. Households with children, and in particular, single moms with children, as well as African American households and Hispanic households, are much higher rates of food insecurity than the national average. Low-income households with below 185% of the poverty line, we find are often food insecure. So in our healthcare sector, we'll identify that while individuals who are uninsured or underinsured, or those living covered by Medicare and Medicaid, are frequently those who are the most likely to be food insecure. If we look at the next slide, food insecurity really exists across the country in every community. And at Feeding America, our Matthew Milgap study looked at a deeper dive into the communities that are affected. And as you see on this map, those that are the darkest green are the ones that have the highest food insecurity rates. And so we find across the country that there are many parts of our states and our communities that have the highest rates. And this is a great study that's done by Feeding America every few years that gives us the data to understand by our zip codes, by our school districts, by our congressional districts, where food insecurity is the most prevalent, and allows us to understand how we can develop interventions to really address the food security needs of those in our community, and help us to work in partnership with one another to find individuals who might not be currently accessing food that they need for optimal health. I'm going to turn it over to Dean to talk a little bit about food insecurity in Pennsylvania. And as I showed you that county map, or that the countrywide map, we do have the breakdown, and that's available at the Feeding America website. And you can drill down into state level and county level data to show. So Jane can talk a little bit more about food insecurity in Pennsylvania.
All right, thank you, Kim. So as far as food insecurity in Pennsylvania goes, you'll see there that we're at 13.1% of the population, which means that about 1.6 million Pennsylvanians are food insecure, and 500,000 of them are children. And you'll see here the average meal cost in Pennsylvania is $2.93. And recently, a study done by the Urban Institute took a look county by county to see if SNAP benefits could cover the cost of a meal. And your average SNAP benefit only covers the cost of $1.86 per meal. So as you can see, the cost of food definitely plays into food insecurity in Pennsylvania. And you're welcome to go to the Urban Institute's website, and you can look county by county to see how the cost of food matches up with any kind of benefits that some families have in order to fulfill that gap. As far as the percentage of poverty, if we can go to the next slide, actually, using Map the Meal Gap, like I said, we had talked about the fact that we found that it was 13.1% of food insecurity rate, but I wanted to make sure that everyone is clear about how that eligibility is determined when we talk about percentage of poverty. So when we talk about a household of 4, your typical household, the people that are outside of the benefits area where they can receive SNAP, WIC, CSFT, or TFAP would be making only $45,000 a year. So we are talking, and then we talk about a household of just 1, we're talking about $22,000 a year. So just making that income makes you ineligible for most of the charitable food through federal and state programs. So when we talk about 100% of the poverty level, a family of 4 may only be making $24,000 a year, a little over that. So going to, do we have something on the next slide here? So I just wanted to, okay, there we go, good. So in 2014, Feeding America did a major hunger study and looked at the U.S. In total, but also looked at Pennsylvania. And so taking into account all the other issues with income that some of these families are facing, 58% of the families that we and our food banks are serving have households with members with high blood pressure, and 33% have household members with diabetes. And you'll see there we have 49% of the clients that are in fair or poor health, and 64% of those households with medical debt. But I think it's also important to recognize that 65% of those households over a 12-month period were trying to make the decision between paying for food and paying for medicine or medical care. And 17% of our clients had no health insurance of any kind. So there's definitely a gap there that we as Feeding America food banks feel that we can provide that medicine through food and connecting our clients with healthcare providers.
So in the next slide, as Jane and Kim referenced the Feeding America Hunger Study from 2014, as a regional food bank, all of the food banks across the country that participated in the study actually went out and surveyed consumers at multiple locations to come up with the data within our own service territory. And so some of the responses from the individuals that we surveyed certainly indicated that their income was not adequate to cover their basic household expenses, and that they had to make choices between paying for food and paying their utility bills, paying for transportation and paying for food, paying, as Jane said, paying for their medicine or paying for food, and paying for their housing. We've had poverty simulation trainings with staff and community members, and actually, participated as a consumer and we're really introduced to the choices that people have to make when they have a certain amount of money to live on. So that's a very impactful opportunity and exercise to participate in. So again, lots of choices that people have to make, and more often than not, food is what is at the bottom of the list when there are other expenses that the family requires.
Thanks, Georgia. So, why does food insecurity matter to healthcare? Why are we talking about these issues today? Because being food insecure affects the health status and the health outcomes of the people living in that household. In addition, food insecurity also affects the bottom line for the healthcare costs to the entire healthcare system. I'm going to turn it over to Judy now to elaborate on what we know about food insecurity and health status.
Thank you, Janice, and good morning. Food insecurity does impact health. Food insecure individuals have increased prevalence of and risk for chronic disease. Some specific examples are cardiovascular disease, heart disease. High blood pressure is 25% more common in individuals with food insecurities. Diabetes, specifically type 2 diabetes, it is approximately 25% higher. Kidney disease, there is approximately 50% of an increased risk, especially with patients that also have diabetes and high blood pressure, along with their kidney disease. Osteoporosis, a decreased density of bone, it is an increase of 4% risk, and this is especially true for women. Obesity, we define it as a BMI greater than 30. It is 2 times as prevalent. And as we go on to the next slide, not only does food insecurity affect chronic disease, but also self-management. Once a food insecure person develops a chronic disease, managing one's health becomes even more challenging. Healthy foods are not always available, which makes it very difficult to control diet-sensitive diseases. Research has demonstrated that people living with diabetes and food insecurity have more medication non-adherence, more trade-offs between food, medicine, and their medical supplies, like those supplies required for self-monitoring of glucose, or needle syringes for their insulin administration. And people struggle more with diabetes distress and low self-efficacy, all of which can lead to poor health outcomes over time. Another study shows that hospital admissions for hypoglycemic increases at the end of the month when people run out of food and resources to manage their disease. These challenges undoubtedly also exist for people living with other diseases, like high blood pressure, HIV, cancer, and even more. And now Kim will talk to us about higher healthcare costs.
Thank you. So we know that food insecurity not only affects people's health status and their health outcomes, but it leads to higher healthcare costs to the healthcare system as a whole. People who are food insecure, because they have more chronic disease, they're seeking more chronic disease treatment. There's great data now that shows that there are more hospitalizations for people with diabetes because they have food insecurity, and more hospital readmissions. These are things that we're really looking across the sector to decrease. And as we look at those high-cost utilizer patients, often we identify them as being food insecure. A recent study from 2017 looked at NHANES data of those who were food insecure, and those patients cost the healthcare system about $1,863 more per year, or $155 per member per month more than their food secure counterparts. When we extrapolate that across all of the individuals who are food insecure in our country, it's a cost of $77.5 billion in additional costs per year to the healthcare system. So in addition to the moral imperative of addressing food insecurity and the desire for us to improve the quality of life of individuals who are food insecure, we know that this is an enormous problem for the healthcare system that we can tackle together. So I'm going to turn this back over to Janice to talk about really why food insecurity results in poor health and what are some of the means by which we understand those situations to be true.
Okay, thank you. So why does food insecurity result in poor health? Thinking back to the coping strategies that Judy mentioned a little in her presentation and that we've mentioned previously, food insecurity creates so many challenges. Poor dietary intake, not enough food, not enough healthy food. More household stress comes with the worry of where your next meal is coming from. Poor self-efficacy and the limited capacity for good health behaviors. If you're eating what you can when you can, it may not be consistent with recommended diet for a health condition. And the cycles of food availability can lead to a binging and fasting cycle that's not very healthy. Health challenges may lead to missed work, spotty work history, decreased employability, and ultimately reduced family stability. Kim is now going to take us through a conceptual framework on food insecurity and chronic disease.
So what we've understood about food insecurity is all of those coping strategies, the poor diet quality, the changes in eating behaviors are what leads to chronic disease. And those chronic diseases bring people into the healthcare system. They have increased healthcare expenditures, which means they're missing days of work, they're having trouble staying employed, which further exacerbates their household income problems and the spending trade-offs that they have to make, keeping them in that cycle of food insecurity. And traditionally, when individuals come to the healthcare system, that's when we're identifying them for an intervention. We're treating their diabetes, we're treating their hypertension, we're hospitalizing them to the complications of those. But what we've really tried to do in some of our work in the Feeding America Network and our partnerships is to think about upstream community interventions. How do we tackle this problem when people are food insecure before they are experiencing the effects of food insecurity and the health impacts of chronic disease? So a lot of the work that we have done over the last many years provides us with this opportunity to think about how we collaborate between food banks and community-based organizations and the healthcare sector to create these upstream community interventions, attack food insecurity before it becomes a problem for individuals. So I'm going to turn it over to Georgia to talk about some of these partnerships.
Thank you, Kim. That was a great segue into part 2 of the webinar today, and I think hopefully everyone's got a better understanding of food insecurity and the connection to health and health care. So the next phase of our presentation is how can we collaborate with you as an organization and other community partners to address food insecurity, perhaps with the patients that you serve. So let's backtrack a little bit to the onset of the Affordable Care Act several years ago and the requirement that's mandated for nonprofit hospitals to do community outreach. As a result of that and the community health needs assessment process that each of the hospitals have to go through, we arrived, at least our regional food bank here and nationally and with a lot of other food banks, we arrived at a point that it was time to really intersect with our local healthcare providers to come up with some collaborative ideas and projects to address the folks that are being served through our emergency feeding network here in central Pennsylvania and certainly elsewhere. So we started to, our first victim, if you will, our first partner was thankfully Penn State Health, which is in our backyard here in Harrisburg, Pennsylvania. And we collaborated with them to create a project at a local food pantry to engage with consumers that are served there and do some health outreach, nutrition education, et cetera, with the clients that are served. And Judy's going to talk about that a little bit later. So the other thing that we realized was the importance of talking with healthcare providers about food insecurity and how they're, point out ways to get them to engage in the process. Very simply, to talk about food insecurity with their consumers, as was indicated in the video earlier, and what to do with that information once someone indicates that they're food insecure, and if at all possible, then to go to the next step and actually engage with consumers at food distribution locations. We'll go to the next slide, which points that out, identifying and addressing food insecurity at the healthcare site. The diagram that's shown here shows that healthcare providers would engage with the food insecurity screening, which we'll come up to in a second here. Then take the next step, not just ask the question, but know what to do when someone indicates that they're food insecure. And that would be to refer them to an existing regional food bank in their area, or a local food distribution partner, a pantry or a soup kitchen type program. Another opportunity might be for that healthcare partner to actually host a distribution at their location. There are a lot of produce distributions, what we call point-in-time distributions, cropping up across the country with healthcare providers providing services to their patients, which has turned out to be very successful. Another way that agencies, healthcare providers can immediately engage in connecting people with food would be with SNAP referrals, food stamp referrals. There are multiple organizations across the country that help to navigate individuals through that process. Sometimes they're a little less willing to go to a county assistance office to apply for SNAP, but many regional food banks actually sponsor SNAP outreach programs and help individuals to connect with other food programs. The next slide is an indication of how healthcare partners can actually engage at a food distribution site, and Judy will talk about that in a little bit about their project. But what that means is that the healthcare provider actually would provide staff or volunteers to go to a food pantry and engage directly with the consumers that are served there. We've found that, rest assured, if an individual is able to come to get food once a month, twice a month, weekly, however often they're allowed to come, they will assuredly show up for that food. They need that food. In order for them to go to a clinic appointment or a doctor's appointment, sometimes life gets in the way and they just might not make it. But if the healthcare provider is on site at a food distribution program, that engagement, that regular engagement and interaction has proven to be very successful to help affect change. The next slide demonstrates the two food insecurity screening tool questions that are standardized pretty much across the country. And these are the questions that, as we reach out to healthcare providers, we're encouraging them to implement this as normal routine process in their patient assessments. The first one is, we worried whether our food would run out before we got money to buy more. They're asked to indicate whether that was often true, sometimes true, or never true for the household within the last 12 months. The second question is, the food that we bought just didn't last and we didn't have money to get more. Again, was that often true, sometimes true, or never true for your household in the last 12 months? Again, this is the first opportunity for engagement with consumers that we're encouraging healthcare providers to employ. We found that with the patient database systems that are out there now, that all of them are required to use, those questions are actually part of the software, but sadly a lot of hospital systems have not activated those questions. And so that's one of our first opportunities to engage with a healthcare provider to talk about the food insecurity screening. I think there's, if anybody has any questions.
Or if you raise your hand, there's a little icon. If your agency does ask these questions of your clients.
Oh, okay. Yes.
Let's see.
Yeah.
Let's see a show of hands. Let's do it. Are you asking these questions? Come on, folks. Raise your hand. Wake up. All right. Maureen, thank you.
So that's one of the challenges that we'll talk about.
All right, not many.
Not many. Okay, good.
All right, well, that's why
you're here.
It's
a jump-off point. Awesome. All right, I'm going to pass it back to Kim for Feeding America's health and nutrition efforts.
Thank you. And we can just talk about the screening questions for one more second, if you can go back to that slide. I want to point out, and so as we mentioned, these are the two of the questions from the 8 15-question survey that USDA does about food insecurity. So the numbers that we gave in the beginning when we talked about 12.3% of people being food insecure come from a much larger survey. And these 2 questions have been validated for use in a screening setting. So if someone answers often true or sometimes true, that checks very closely to the way that they would answer to the full survey. And I think what's really important about using these 2 questions is it gets at both of the aspects of food insecurity. That first question is, we worried whether our food would run out before we got money to buy more. And that might be that the family or the household was able to make ends meet, but they worried about it. And it takes a lot of bandwidth. It takes a lot of mental energy to assure that you have the food to feed your family when you're living in a food insecure household. And we know that this is a cyclical problem. It might be more of a struggle in the wintertime when you live in an area that's colder. It might be more of a struggle when the car is breaking down. So there's a lot of stress and the bandwidth problem that people have, even if they are able to put food on the table. And then that second question really gets to the food we bought didn't last and we didn't have money to buy more. And so were we actually having to skip meals or make trade-offs between buying our medication and buying the food? And this time we had to choose to buy our medication. Or, and so what we know about food insecurity is that there's levels where people are having to make trade-offs about the quality of the food that they're eating, which is certainly leading to chronic disease. And then they're also having to make trade-offs about the quantity and skipping meals or snacks or and really cutting back on what they're eating. And so I think what I like about these 2 questions is it allows you to understand where your clients, where your patients are coming from and where they are in their journey to be able to access healthy food. And so at Feeding America, we have really embarked on a variety of partnerships and research and efforts to understand what we can do as a network of food banks to address this. And so our assumptions are that if food insecurity is leading to poor health, that improving food access and improving diet quality will contribute to decreasing risk for diet-related diseases. It'll help our individuals who are food insecure to manage their existing disease, and ultimately we can play a role in improving individual and population health outcomes. So the approach that we've taken as a national organization is to work with food banks around the country to test some of these hypotheses and build the evidence through a variety of pilots focused on distribution of healthy food, through healthcare partnerships and referrals, through screening and education. And we are working to disseminate and scale the aspects of those that are effective and build the capacity of our food bank network and their agencies to be really good partners in health promotion for the healthcare organizations in the communities. So we are not looking to provide healthcare in food banks, but really work together to be sure that we're meeting those individuals where they are in the community with the kinds of services and health care access and healthy food that they need. So I'm going to tell you about a couple of the research efforts that we have done so far. We launched into this in 2011, focused on diabetes through a project with the Bristol Myers Squibb Foundation, and they're Together on Diabetes project. And so Feeding America was one of about 27 organizations around the country, part of a $50 million investment by the Bristol Myers Squibb Foundation to understand how to tackle diabetes. And you can go to the next slide. And so we worked with 3 food banks to do an intervention where we screened for diabetes in the food pantry setting. So we were actually checking hemoglobin A1C levels and talking to individuals who came to the food pantry about diabetes, as well as screening for food insecurity in diabetes clinics. And then we enrolled those participants in a 6-month intervention where they got access to healthy food that was appropriate for their diabetes education, referrals back to a physician if they didn't have one, and support for blood sugar testing. We made sure that they had access to the supplies that they needed and understood how and why to do that. And we saw in this prospective study, we saw improvements in hemoglobin A1C. So we saw improvements in blood sugar control. We saw that the clients that were enrolled in this were improving their fruit and vegetable intake, so having an improved diet quality. And then they had better self-efficacy. So they were telling us that they felt more equipped to manage their diabetes, and they weren't having to make as many trade-offs with their medications. And so in the beginning, they were telling us there was a lot of skipping medications to be able to afford their food, and that was less as they went through the project. So as a follow-up to that, we did a randomized control trial with 3 different food banks, one in California, one in Michigan, and one in Texas. And those individuals were all recruited from the food pantry setting. It's a little bit easier to structure that in the randomized control trial to a 6-month intervention or a wait list. So everybody eventually received the intervention. It was twice monthly boxes of food, and then this time it was scaled to the household size to be sure that we were really addressing the food insecurity for the whole household so that the individual living with diabetes got the dose of food, if you will, that they needed. And again, a little bit more robust diabetes education based on what we learned from that initial pilot project. And again, referrals and blood sugar testing with support for those who didn't have a physician or who weren't really plugged into some of the supports that might exist. So again, we've seen some great results from that, and those have been submitted for publication, so we'll be able to talk a little bit more widely about that in the coming months. But and then we're also including a healthcare utilization analysis to understand how being enrolled in a project like this supports use of, going back to their physician and accessing ongoing care, as well as if it has any impact on their use of emergency rooms and other things. So that has led us to thinking about if we can show some improvements in diabetes control by supporting individuals who are food insecure, can we see any improvements in diabetes prevention? And so right now we are working with 2 different projects to understand that connection. And so we all know that the YMCA diabetes prevention program has been very well tested and understood in, around the country. And so but that project is very specific to the educational curriculum that they have used. And so we're working with the public health school in Pittsburgh and the YMCA to work on the addition of food to the diabetes prevention program. So identifying in a low-income community where the DPP is being run, providing people with access to healthy food to see how that has impacts the individual's ability to manage their health and hopefully prevent diabetes, and what kind of an impact that has on the partnership and the utilization of those DPP programming as well. In addition, we've connected with AmeriCares and the National Association of Free Clinics to do some work with diabetes prevention programs in the free clinic setting. And so we're doing a similar study of the addition of healthy food for people who are food insecure, who are accessing the DPP through a free clinic, and really finding right off the bat that there's lots of enthusiasm by the participants, and they're actually identifying that people are coming more often to those classes. And we all know that in public health it's so difficult to get people to come into educational programming, but when we add the food component, it can really help folks to understand how to use those foods and get them excited about eating healthy foods and choosing healthy foods with their own purchasing dollars. We've had some great success there. And so now we're really starting to think about how do we shift in the big picture and not just think about getting access to healthy food as a charitable sector, but can we have some collaboration with the payers to ultimately see food as a covered benefit for those who are low income and food insecure and really struggling with their health. So we have a pilot project going on, or a project going on with Humana with the food bank in the Miami area, feeding South Florida. So our pilot was in 2016 in Broward County, and this is one of the Humana's bold goal areas, really wanting to see if they can improve quality of life for the members of Humana and the communities at large. And so we did some screening just to really understand the connection between food insecurity and healthy days, which is the measure that they use. And if you're familiar, CDC has this healthy days measure where we ask individuals if they have over the last 30 days, how many days they've been physically unhealthy and how many days they've been mentally unhealthy. And that is a measure that Humana has used. It's obviously very easy to quantify. You get a number 0 to 30 for each of those. And so they're looking to see if they can improve quality of life through improvement of healthy days. And so we screened individuals for food insecurity in the outpatient clinic setting to understand what was the prevalence of food insecurity and what's the connection between food insecurity and health status for those Humana members for whom we could access some claims data and see a little bit more about their health status and their quality of life. And so over the course of 4 weeks, we screened 369 patients. They were all using the 2-question screen. And in a community where about 15% of patients of individuals in the community, where the community food insecurity rate is about 15%, 51% of all patients in that clinic setting were food insecure. And I would say that was a surprise to all of us. We knew that people who were coming to the outpatient clinic who were likely to have more chronic disease, we'd see a higher prevalence, but over half of all those individuals were food insecure. And I think that's a really important starting point for those of us working in outpatient community health, because it was very surprising to these clinicians and medical assistants. They said, oh, we don't think it's that high. And in fact, half of them were. And 77% of the Medicaid or dual eligible patients were food insecure. So very, very high rates of food insecurity amongst those most vulnerable populations. And food insecurity, not surprisingly, was associated with higher rates of mentally and physically unhealthy days. In fact, they were about twice as high. So people who were food insecure had twice as many unhealthy days, and they were twice as likely to have more than 14 unhealthy days a month. So again, reminding us that food insecurity is significantly associated with poor quality of life. So we have taken on a phase 2 randomized control trial to see what we can do about making an impact on those quality of life and on health status if we then enroll individuals into a year-long intervention to support them with access to healthy food. So we've screening individuals for food insecurity and inviting them to participate in this randomized control trial. Will they have access to a mobile distribution? So back to George's her slide before, where we think about sometimes we can refer to existing sites. Sometimes we can start new distribution points at the healthcare site to be sure that we're meeting people where they are. And so we've added some mobile food distribution programs to create new access points to healthy food, as well as connecting those individuals with existing food pantries, a choice pantry that takes place at the food bank, so they're getting more access to the resources in the community. And then we're doing a lot of work to be sure that we're connecting individuals with the long-term benefits that they're eligible for. So helping them apply for SNAP and really encourage them to use their SNAP benefits if they're not, so that they can expand their purchasing power. To connect them with what we're sort of calling, food for today, the mobile food distributions and the food resources that they can get through the emergency system, and food for tomorrow, so that they have the resources to make the purchases that they want in the community. So we're in the midst of this. We have enrolled about 700 patients into this trial, and will continue through the end of 2017 with results to look at clinical outcomes as well as business metrics. And we're really anticipating the ability to see some improvements in the cost for patients to the payer. As we do this, we're embarking on some work with several other insurance companies who are really interested in ways that they can engage either directly with their members or through community health centers and other providers to be able to support the food security status of their members. So there's lots of opportunities happening right now, and we're really excited to see the healthcare sector so engaged in the way that they can make a difference for patients.
Thank you so much, Kim. How did you know there was a question just on that topic? Kim, there's a question from Kristen. Thank you so much for the question, Kristen. She's asking whether health plans, insurance companies are being engaged in conversations regarding how food insecurity is affecting healthcare costs. It seems that they should have an interest in tackling this issue for those with high utilization and healthcare costs.
Wow.
Great question, Kristen. And yes, absolutely. They are starting to take notice, and it's really a lot of fun for us right now to be able to talk with health insurance companies. And I'll tell you that we have, beginning conversations with about 4 different organizations right now. So Feeding America and several health insurance companies who are starting to think about what the opportunities that they have. And I will say with Humana, one really interesting opportunity that we have there is that Humana, those clinics, those continued care clinics that I mentioned that we worked in, those are physician owned. And so in that setting, we had kind of a payer-provider entry point, which is not always the case with a health insurance company. So we were able to say, Humana said, this is a priority for us, and so we will do this. And they had direct access from insurance company to provider to member, so could really direct what they wanted to do there. And so that was an easier start than in a place where there's multiple layers. But we know that all of the insurance companies have, or many at least, the ones that we've spoken to so far, have population health and personalized health departments that are really thinking about how do they not just pay for the claims, but how do they support the health and well-being of the members. And so we're really working with around the country in a variety of ways to test out some different models of, making phone calls or working through community partners or working through outpatient clinics to understand, do we want to tackle this problem as a whole? Do we want to really think about food insecurity for everyone? Do we want to think about how we address the issues of the highest utilizers, maybe the ones who are suffering the most from food insecurity and other challenges that have led to chronic disease? So there's a lot of kind of trial and error right now, I think, but there's a lot of interest because health insurance companies are really taking notice that social determinants of health are where we have the opportunity to make some big improvements. And I will just say, too, that the biggest excitement for us in the last couple of months is that the Center for Medicaid and Medicare Services has released some draft language about including food or supplemental benefits, which would include food, as a covered benefit for Medicare Advantage starting in 2019. So that would mean that when we identify people who are struggling with their health because of a chronic disease and need either medically tailored meals, kind of a meal intervention, or a grocery program, that could potentially become a covered benefit. So that's the first sort of broad stroke discussion about providing reimbursement through the health insurance sector for what we know to be, this really important health promotion opportunity. So thanks for the question.
Thank you. Thanks, Kim.
Okay. Kim, thank you very much. The results that you came up with in the Broward County, pilot, I thought were pretty outstanding. It just, kind of raises for us that you don't really know what's going on with people until you ask the questions. So I have a question for you, audience. What type of interventions are currently used at your agency? We have 4 choices for you. 1, we identify patients with food insecurity by asking the 2 food insecurity screening questions. We give referrals to clients to access food pantries in the area. 3, we give out materials on SNAP and other resources. 4, we currently do not use any of the above interventions. Would you please note your answers now?
And people are voting. Oh my God, they are. All right, we'll give a few more seconds here. Thank you for making your choices. Overwhelming response that you at your agencies, you are giving referrals to clients to access food pantries in the area with 70% of the vote. 57% of you, they're giving out materials on SNAP and other resources. 14% of you're currently not using any of the above interventions. And 7% of those on this call are identifying using the food insecurity questions. Thank you. Thank you so much for your participation.
All right, thank you for your responses. At this time, I'd like to take just a moment before we move to examples of Pennsylvania health outreach projects to acknowledge some additional current programs and activities. This information came to us as a result of the pre-survey questionnaire on current activities. So, starting us off, Joan Boyce from Einstein Healthcare Network reported a relationship with Philabundance in Philadelphia, which is their food bank there, and their pop-up produce distributions. Food insecurity screenings are also in place. Nutrition education about the SNAP education program are also in place and have been in place for about 5 years. Jen Bauman of the Berks Community Health Center is working with the Greater Berks Food Bank and their mobile food pantry, as well as having a connection with the Reading School District and their summer lunch program at one of their locations. This has been in place for 1 to 3 years. Maureen Herman from Primary Health Network does food insecurity screening and provides food program referrals. This has been going on for 1 to 3 years. Welsh Mountain in Lancaster County and Hamilton Health Center in Dauphin County both refer consumers to food pantries if need be, and Hamilton also works with other partners in the community to do health screenings off-site. Several respondents indicated a strong interest in learning more about food insecurity screenings and working with food pantry programs. So thank you very much for letting us know about the activities that are currently going on. And I'll ask if there are any comments at this time.
How did you know, Janice? There is. We want to thank this individual with a comment. Let me make sure I know who to recognize. Here we go. And Kristen, again, thank you so much. She is working with 12 RHCs in North Central Pennsylvania that are owned by a CAH. We also have a home health agency. We are looking at addressing food insecurity as a strategic priority to improve the health of our patient population through our newly created Northern Tier Community Health Collaborative. Our goal is to start screening over the next few months in all of our healthcare settings. Fantastic, fantastic work. And we had others that sent in responses. We thank you for all those efforts going on. Thank you so much.
Well, we're excited to hear about all of those activities. And now I'd like to turn it over to Judy Dillon to talk about the excellent work that's being done at Penn State Health.
Thank you so much. Yes, Penn State Health has a multi-pronged approach with a focus on increased fruits, vegetables, assessment, and health education to individuals with food insecurities. Today, I would like to briefly describe 5 of our initiatives to you. The first one is our farmers market in Hershey. This year will be our 8th year in operation. It opens mid-May through October, 2:30 to 6:30. The vendors are local farmers. There are free activities for the family and children, along with nightly concerts. It is located on the backside of our campus at Cocoa Beanery. What's most important about this conversation today, though, is our Wellness on Wheels, or as we call it, our WOW program to our underserved communities. We take fruits and vegetables weekly, along with nutritional education and recipes, to 2 underserved populations in Dauphin County. On Thursdays nights, we partner with the Lower Dauphin Community That Cares to locations they serve with their bookmobile. And on Friday mornings, we partner with the Penn National Racetrack to serve employees, families of the racetrack, along with the Grantville Food Pantry. Last summer, we distributed over 2,000 pounds of food. Our 2 programs are sponsored by local grants from the Giving Tree of Hummelstown and Hershey and the Community of Cares of Lower Dauphin. Next is our community garden, our Hershey Community Garden. It is now beginning its 4th season, and it is a fabulous collaboration of entities, including the Hershey Company, Milton Hershey School, Penn State Health, Hershey Entertainment and Resorts Company, and the MS Hershey Foundation. We are truly recognizing we can't do this work alone and we need to collaborate whenever possible. It offers an opportunity for community residents to grow fruits, vegetables, herbs, and even flowers. It opens mid-March through November. Starting this year, we will have 225 raised bed garden plots for community members. Our student plots. Students garden one-on-one with some of our patients with eating disorders. And in addition, excess produce from the garden is distributed to local food pantries every week. We also do have a refrigerator for storage at the garden. This past year, we distributed over 650 pounds of produce to the local food pantries. Number 3 is our Food as Medicine program. These initiatives are run completely by our medical students with a faculty advisor, Dr. Danny George. Prescription as produce. Physicians can prescribe food as medicine to their patients in need, and they are given the opportunity to come to our farmers market 4 times over the summer. Cooking classes. We have students that are working with the Salvation Army Food Pantry. They go to the food pantry with the client, they help them make choices of the food for the day, and they go directly to a kitchen to cook and prepare meals for that week. Nutritional education and vouchers for produce. We have medical students, and we are referring to them clients in need from both the food pantries and our medical groups. They, the students, go with the clients to the grocery store, wherever their local grocery store may be, farmer's market, a corner store, or a grocery store, and help them make healthy choices, healthy options for them and their family. They go 6 times, and they get up to $40 per visit. And last is the CSA program. The CSA program is in partnership with the Grantville Food Pantry, and CSA's boxes are delivered on a weekly basis to them during the summer months. These initiatives are funded currently by the Association of Faculty and Friends, Dauphin County Medical Society Alliance, and Community Relations Startup Grants. Number 4, our PAWS program, Pantries and Wellness Support. This includes monthly health education, blood pressure screenings, along with ASCVD, Atherosclerotic Cardiovascular Disease initiative. We do it every 6 months. It is a finger stick for glucose and lipids, along with blood pressure, BMI, and smoking assessment. With these values, we calculate a cardiac risk score, estimate the patient's, the client's cardiac risk for the next 10 years, and do one-on-one education with the clients. We began this program in March 2017, a little over a year ago, and currently we have seen over 200 clients with 36 referrals. The referrals are for clinical care follow-up, smoking cessation, nutrition, and financial counseling. Our initial results show that this population have increased blood pressure values, increased cholesterols, glucoses, BMIs, and also many more smokers than the general population. We hope as we continue to monitor, educate these clients, we will improve their values along with their health behaviors. And our last initiative is our most recent one, and it is what we call our Emergency Food Box Initiative. Currently, it is in our PEDS clinic at Hope Drive. We have initiated assessment for social determinants of health. You can see the form on the screen, and one of the questions is the questions we reviewed earlier for food insecurities. This is one of our initiatives for population health. If a positive response from the patient is received, they then see a social worker that day. The social worker meets with the family to do a more thorough assessment. If a need for food is identified for that family, they are given an emergency food box that day. Enough food for the family for 3 to 4 days. Along with the food box, an assessment's done for SNAP, for WIC, and also a referral is made to their local food pantry. We began the program in early fall, and we've given out more than 80 food boxes to 39 families. Our goal, our plan, is to expand to all of our medical groups over the next 2 years. Our collaboration with Central PA Food Bank is key to our success for these programs. We sincerely thank them for their partnership with us. For each of these 5 programs, we collect and we measure our impact. We hope that our initiatives are improving the health of the individuals with food insecurities. And next, Jane will speak about the PA Feeding America Food Bank map.
Okay, thank you very much. Again, my name is Jane Clement-Smith, and I'm Executive Director of Feeding Pennsylvania. And while we are affiliated with Feeding America, we are a separate 501c3 partner state association. So we represent Feeding America food banks across the state, and our 8 members deliver 138 million pounds of food annually through a distribution network of more than 2,600 agencies, which would include pantries, soup kitchens, shelters, and feeding programs. So our mission is to find ways to better collaborate as food banks to provide more funds, more food, and a shared voice on hunger issues across the Commonwealth. Our food banks have spent the last several years dedicating their mission to increasing capacity to handle more fresh and nutritious food. They did this through investing in cooler space, refrigerated trucking, and agency capacity, so getting coolers for the agencies to be able to handle the fresh product, and things like cooler bags to be able to transport the product. Increasing this healthy and nutritious food meant development of several programs, including a produce cooperative that went live last summer, that would take advantage of the growing season within Pennsylvania, as well as the imported product that comes into the Philadelphia port. There's a lot of excess produce that we found was either going to waste or being completely either being dumped or being plowed under. And so through this cooperative, we've been able to access more and more produce. Our food banks are now doing more than 20 million pounds of produce a year, and that continues to increase year over year. We also developed a fresh milk program called Fill a Glass with Hope. It was the first statewide charitable fresh milk program in the country, and it offers fresh milk to families in need. And we did this through partnering with the Pennsylvania dairy industry and being able to purchase that fresh milk directly from our local dairies. That program has done more than 7 million servings of fresh milk since 2015. And this became a top priority because when we talked about the hunger study several slides ago, milk was one of the more requested items in our food pantry and is rarely donated, but obviously has essential nutrients for families and children in need. We also do advocacy efforts across the state for federal programs to access fresh surplus product, including produce, fresh meat, and fresh dairy products. So like I said, we've really been dedicating most of our time to changing the view of the food bank into just shelf-stable food. And while we realize that is still very important, we feel we have a real role to play in population health and in making fresh product available to everybody in need. And so if we can go to the next slide. Taking into consideration that we've built a lot of that capacity, over the last 4 or 5 months, we've been working as a state on a partnership with the Pennsylvania Department of Health to work on a statewide healthy pantry initiative. The Department of Health came up with data that called out the top 34 counties in Pennsylvania with food insecurity, the highest food insecurity and the highest obesity rates. And so taking those top 34, they ended up covering 5 of our main food banks. So we're looking at the Philadelphia region, central Pennsylvania, the Northeast, the Northwest Erie area, and Pittsburgh, and looking at creating a template healthy pantry initiative that would work with pantries in each of those regions. We're looking at 365 food pantry locations to help them continue to increase their capacity to accept fresh product through equipment and racking and storage capacity, but also through education and wellness materials. And by doing this partnership, we're looking at hiring a registered dietitian that would be working in Feeding Pennsylvania, and then having nutrition educators in each of those food banks. This would all, like I said, be part of a partnership with the Department of Health and a federal block grant that they receive around increasing access to healthy food and beverages. The program is in the development phase right now. There's a task force statewide that's looking at best ways to implement this project. There'll be many partnerships for implementing the educational materials, but we're also hoping to take each of those food banks who have relationships with healthcare partners and also wish to increase their relationships with healthcare partners to be able to bring the healthcare side of it in, not only to gather the data and results as we do this pilot program, which will be a 5-year pilot, but also to help connect families with the fact that nutritious and healthy food and being able to access it and cook with it and work with their families on increasing having those products within their home, and how that basically rolls out into their overall health. So we're hoping to be able to continue that partnership across the state over the next 5 years.
Thank you, Jane. And now to Georgia.
Back to Georgia again. Another example of a pretty exciting project that the Central Pennsylvania Food Bank has been engaged in over the last probably 18 months to 2 years is a program that Geisinger Health System began, which they're calling the Geisinger Fresh Food Pharmacy. They have implemented a food pantry program on site at their Northumberland County location in Shamokin that specifically serves diabetic patients in their clinic who had A1Cs that were over 8%, or a reading of 8. They started out with 6 patients in that clinic, and now they're up to nearly 200 households. Actually, they're now treating not just the patient, but the entire household. And consumers are permitted to come to the pantry once a week. It's a choice pantry where they choose foods that are available to them: whole grains, fruits and vegetables, lean meats, etc. They receive dietetic counseling. They have health and wellness classes that they participate in for health education, and certainly pharmacy services, etc. The program has been incredibly successful with A1Cs dropping, weight reduction. If you listen to Dr. Andrea Feinberg, actually we have a video clip that will be available to you after the presentation, but she states that it is 100% successful. This project is 100% successful. Their intent is actually to replicate this program in other locations. They are about to open a program in Lewistown in Mifflin County and also in Scranton, probably this summer. And their intent is actually to open programs throughout their network. The other thing that Geisinger has implemented, which is very successful, or about to launch this month, is the food insecurity questions in their patient database system. They will do that system-wide. So those questions will be asked both in Pennsylvania and in New Jersey on a routine basis. And then they've actually hired staff to assist patients who indicate that they're food insecure. They've hired patient navigators to help them to connect with food distribution programs in their community. So it's been a great partnership, and certainly one that can be replicated elsewhere. And they're very, very open to talking with anyone that has any questions about that. We did put their website on there where you could access more information on that pharmacy program, and they have their contact information on there as well. Another way to engage, as I had mentioned earlier, is SNAP outreach. And this is something that healthcare providers can start immediately. We, as a regional food bank, as I mentioned earlier, have a helpline number that we help to promote throughout our service territory with healthcare providers and other social service organizations to actually have folks call us, and we will do a brief screening with them, and if we find them eligible for SNAP, we will facilitate their application over the phone with them. Last year, we did roughly 2,000 applications. I think this year our goal is about 2,800. So it's been very, very effective. SNAP is, as Kim mentioned, food for tomorrow. Food for today is from the food pantry. Food for tomorrow could be related to their SNAP benefits. And it's a wonderful benefit program that is underutilized in Pennsylvania. There's a lot of counties where percentages are very low in SNAP participation. So all of the food banks across the state are helping to promote that. Joe Arthur, our executive director, is here, and I wanted to give him a couple of minutes to just talk about the SNAP program and its importance in the emergency feeding network.
Thank you, Georgia. And thank you to all the folks that are attending on the call, and certainly to our panelists. And I won't take a few minutes, but I'm going to highlight something very important. We've mentioned numerous times how important SNAP is to folks that are food insecure, and we've been tying that into the importance for their health and health outcomes. 2018 is a critical year for SNAP in that the Farm Bill, which is the legislation that includes SNAP funding and WIC and a host of other nutrition programs, and that is currently being discussed and negotiated in Washington. And you may have noticed that Feeding Pennsylvania and Central Pennsylvania Food Bank have been jointly convening roundtables here at our Healthy Food Hub to raise awareness about the Farm Bill. So we're going to continue to do that, but I wanted to make all of the listeners aware we do need your help. We've built a coalition with agriculture, with our friends in the grocery industry, with farmers markets, with farmers themselves, and healthcare as well. And you as healthcare partners could be a critical voice to make sure that we protect SNAP. And the best way to do that is to get involved and support a strong Farm Bill. So wanted to point that out, and then we'll turn it back to Maria.
Thank you, Joe. Thank you so much for that information. With that, we're going to have Kim go over some of the overarching programs through Feeding America that are available. Thank you, Kim.
Sure, thank you. And I just wanted to echo the, again, the importance of SNAP. You know, we talked before about the cost of food insecurity to the healthcare system. Well, one of the things that we have identified is that SNAP, you know, while SNAP is a food security program, a food security support, it works really well at assuring that people who are accessing SNAP benefits get the healthy food that they need. It improves people's food security status, improves their diet quality. There's new research that also shows that people who are receiving SNAP benefits cost the healthcare system less. And this is a study that I can send to Maria to share at the end. But in the journal, in JAMA just a few months ago, the researchers found that people who are enrolled in SNAP have healthcare expenditures that are on average about $1,400 less a year compared with similar people who are not enrolled in SNAP. So again, a really important program, not just for food security, but for healthcare as well. And so as we think about some of these other programs that are providing the food for today, or the emergency food access, or even the ongoing access to food, we see around the country a variety of programs that are really designed to meet the unique needs of the community. So kids cafes are after-school programs designed to provide meals and snacks that are healthy, along with some nutrition education, to provide kids when they are in an after-school program with a meal with the nutrition that they need, and also the education about nutrition, and understanding and a motivation to eat healthier, to be certain that we're supplementing what they'll get at home. And so many kids who are in after-school programs until 6 o'clock at night. They need something beyond just a little snack. And so these programs work with food banks and their community partners to assure that those exist. School pantries have been a really big outgrowth of both the kids' cafes and really just understanding that children who are getting breakfast and lunch at school during the week go home to relatively empty cupboards. And so we've started to see lots of great successes where food banks will partner with schools to provide pantry programs for families to come and get a bag of groceries when they pick up their kids, or the backpack program where we actually put the food in the backpack that goes home with the children. So that we're using the school as an entry point to be certain that families have access to the food that they need. The summer food service program is the USDA program to assure that individuals have access to healthy meals in the summer when school meals are out. And around the country, we hundreds of our food banks are participating in that program and making sure that we're getting summer meals and snacks. And sometimes those are individual sites, and sometimes those are coupled with summer camps and YMCA programs and others. And there's great policies in place to assure that if we have a low-income community, that we're not having to individually enroll and make sure that individual kids are eligible, but a whole community can kind of be deemed eligible for summer food. And so there's great opportunities to think about that in outpatient clinics, and we're even seeing summer food programs popping up around the country in some hospital settings. So there's so many ways that we can structure these programs to take advantage of the infrastructure that exists, taking advantage of classrooms in an outpatient clinic, the cafeteria in a hospital. So really thinking about what kinds of resources can your organization bring to the table, and how can that be used, whether it's on an ongoing basis, just in the summer, even just occasionally, to serve as a site to support access to healthy food. The CACFP program, Child and Adult Care Feeding Program, is a program of USDA that makes meals accessible to early childhood settings. And so those are programs through Head Starts and some of the other early childhood programs, as well as some adult senior programs. So those are other ways that we can find funding and support to make sure that folks in the communities have access to healthy food. And I'll turn it over to, the next slide is to tell you a little bit about our hungerandhealth.org website. And so this is a microsite of Feeding America. As a national organization, we have a lot of resources that we've created to support our food banks as they embark on some of these partnerships. But what we have learned is that it's much more useful when we can see some of the same information and make our resources and our learnings and our great examples that we've found from Pennsylvania and other food banks around the country available to not just food bank staff, but their partners. And so we created hungerandhealth.org. That is a website run by Feeding America aimed at educating and connecting and engaging cross-sector professionals working with food insecure communities. And so we have a variety of resources and tools about healthcare, creating healthcare partnerships, making sure that nutritious food gets to individuals in need. We've done a lot of work with not just behavioral economics to be able to encourage individuals to make those healthy choices. There are some recipes and targeted nutrition education materials for individuals who are food insecure. And this is not just another recipe site, but a variety of tools that have really been vetted for this population. One of the things that we heard in our diabetes work is a lot of individuals telling us that they had never been given diabetes education or told that they should eat a healthy diet specific for their diabetes needs. And I don't think that around the country no one is telling food insecure people how to eat for diabetes, but I think that a lot of our nutrition and public health messages are lost on some of these individuals because they have so many challenges. And so we're really working to support the creation and dissemination of some resources that are a little bit more relevant for maybe the situation that they have. And so thinking about recipes that have fewer ingredients, recipes that can be easily modified, to use foods available from food pantries and at a lower cost, and those kinds of issues to ensure that all of our work is really going to be successful with the most vulnerable people in our communities.
Okay, perfect. Thank you, Kim.
Thank you very much, Kim. I have a parting thought for your consideration. From your role as a healthcare or human service provider, what potential solutions do you envision to help build healthy and strong communities?
Whoa. That's huge. That's huge.
It's a little challenge.
Just a little challenge. Just a huge challenge. Definitely. Now's the time for some questions or comments from the audience, and we have a question directed towards Judy. Not to put you on the spot, but here's the question. Asking about challenges or lack of integrating some of the screenings and different projects that you're doing into the normal workflow process. How hard is it to do the screening and make the referrals? How receptive have your staff been? Judy.
Oh, great
Take
question.
a few moments to get
This could be a whole new webinar. Let's talk workflow first. I do have 3 community health nurses that work with me all the time, so it is a constant staff from our side. And for the workflow at the pantries, we are now in 6 different pantries, and it is a little different for each pantry, and it has been a work certainly in progress. We find we are definitely the most successful the 45 minutes before the pantry opens for those clients that come early and are sitting and waiting. They're very open for education and for conversation. For the pantries that we have been to now for over 3 years, we have gotten to know many of the clients extremely well by first name, and they really do come back after they load their groceries and just want to talk and for us to listen and to have their blood pressure checked. So it definitely takes time to figure it out. Each one's a little different, and I think the key is the trust that we have to develop and for really being a good listener when we're in the pantries and not to interrupt the flow of the pantry, because the primary reason for the client to be there is to obtain food. So how we can coordinate with that process and not get in the way. The receptiveness of the staff from the food pantries, some were very open the first day we walked in, and others it's taken a little more time. Georgia and the Central PA Food Bank has been extremely helpful in introducing us and making sure that we've communicated what our role is there, along with the NEAs, the Nutritional Education Advisors from the Penn State Extension, who go on a regular basis that really know the population well. We do use standardized tools for education that we use at all of the pantries, and so that all of my staff going out are using the same education, the same process. And again, it is a combination for me of paid employees along with volunteers. And then I think your last question was about referrals. And you're right. This has been, I think, one of the more time-consuming and challenging pieces for us. We certainly think anytime we see a high blood pressure, we want to get them to the doctor the next day, and we want referral, we want follow-up health care, and we just have to be patient. A lot of times it takes 3 months, 6 months until that client is ready, and it's our priority as a healthcare provider, but many times they're still dealing with those basic needs of hunger or electricity in the house or whatever. And so we truly try to continue to work with them until they're ready and until they can make that decision. And it can take a really long time. But I think having the same staff there, sometimes we're there every month and sometimes twice a month, and just being available and ready when they're ready is the key to that solution too.
Perfect. Thank you so much, Judy.
Yeah.
Thank you. And to Janice's parting thought here, we want to hear from you, what you're doing, how you could tackle this question, your vision to build healthy, strong communities. Please raise your hand, then we'll unmute you so we can hear you live. We want to hear your voices. So please take a moment to tell us your thoughts at this time. And we don't want to call on someone.
No.
I think too, just as people were thinking, I think too, part of that last question might have been a question about the healthcare system in general, asking the two food insecurity questions as providers, and the complexity of that, the follow-up that needs to be done. Is that a challenge? I know that you shared an article with me recently about the other side. It's, we advocate for this, but we have to understand the healthcare providers' challenge in that regard as well. So I think that was kind of too where that person was, not knowing for sure, but it might be a good thing to speak to for these providers.
I certainly agree. That is why we're rolling it out gradually, and started with one of our clinics where we had physician champions that were very much behind us. I think we have our clinicians and our nurses are very afraid of getting answers without solutions and without pathways for giving the correct follow-up. For our clinics, we don't have social workers in every one of our clinics right now. So if they get yes, and they don't have the resources to manage that day, there's a big concern of having more information than you can deal with. So I think it is a huge problem. Another problem for us, we have an older EMR system, and so we are using paper. And having to go back to a paper process is not really positive for our clinicians either, but we will have to rebuild our EMR to put the two questions in. And so we have to go through our IT, our leadership, and anybody that's working in a large health system knows how difficult that can be to get approval for addition questions. So we're wanting to make sure we have process in place again, and why we're doing the pilot, so that we feel comfortable with what we're doing and that we really are responding to the questions and giving the resources needed to the clients that we identify.
Really briefly, I just want to share that the CDC Nutrition and Obesity Network Policy Research and Evaluation Network, Blueprint of the CDC, has created, they have a safety net working group that's created some algorithms about clinical linkages. And so these go through help giving providers some resources to think about what else they need to do if you identify an individual who's food insecure. So beyond making that referral, should you be thinking about additional lab tests and additional, thinking about medication changes or the way that you educate the patient. So I just sent that link to Maria and the team to send out, but there is an algorithm for working with pediatric patients, one for adult patients, and one for patients living with diabetes, specific to clinical considerations for healthcare providers for patients with food insecurity.
Perfect. Okay. Part of the presentation does provide some video links for you that we encourage you to check out on your own time. Some additional videos that have been that are related to our topics today. I want to thank all of the participants, all the panelists, and their contact information is here for you if you'd like to reach out to any one of us for further information. And I want to thank Maria as well for helping us to navigate this process. She's a great facilitator.
What fun. Let's stay on all day.
And Serena. Serena, thank you for this opportunity to present to your members and other individuals that have been interested in this topic. We appreciate the partnership, and we look forward to more collaborative opportunities. Thank you.
Thank you. Wow, what a great time. Heavy topic, lots of impact here, but I know that this is getting the conversation started. So we want to hear from you. There's going to be after we close the session, a little survey for some feedback for our presenters, for our panelists, for future trainings for us, and also to connect you, if you haven't already, with your regional food bank. We'll make those connections. Georgia will assist in her team. You will all receive the follow-up presentation, this lovely webinar recording. You'll get it too. So we thank you for all our participants. We thank all our panelists. We thank everyone. We hope that you have a great day. Thank you so much, everyone. Take care. Bye-bye. Bye.
Thank you.